Welcome to Lecture Boss. My name is Dr. David Averbach, and today we will be discussing primary and secondary hemostasis. We have a student in the hot seat today who will be answering my questions. Let's start from damage to a blood vessel and the endothelial cells that line it. First, we must stop blood flow to allow a platelet plug to form. What molecules will vasoconstrict?
Endothelin and thromboxane.
Correct. What molecules cause vasodilation and oppose clot formation?
Prostacyclin and nitric oxide.
Correct. What molecule will bind to the damaged subendothelial collagen to promote platelet adhesion, and where is it released from?
Von Willebrand factor, and it's released from endothelial cells and alpha granules of platelets.
Correct. How does von Willebrand factor mediate platelet adhesion?
It binds to GP1 on platelets.
Correct. And how can you assay this binding?
I'm not sure of the assay.
You would use the ristocetin assay. If either GP1 is low on platelets or you have a von Willebrand deficiency, you have an abnormal assay. What disease has decreased GP1 on platelets?
Bernard-Soulier disease.
Correct. Test writers will list both von Willebrand disease and Bernard-Soulier in answer choices because both have increased bleeding time and an abnormal ristocetin assay. But how would you distinguish these diseases?
In von Willebrand disease, factor 8 levels can be low because von Willebrand factor stabilizes factor 8. So PTT may be high. Factor 8 levels in PTT are normal in Bernard-Soulier. Platelet count is normal in von Willebrand disease. Platelet count is low and the platelets are large in Bernard-Soulier. Von Willebrand disease has a stronger family history because it's autosomal dominant, and Bernard is autosomal recessive.
That's correct. I remember Bernard-Soulier has large platelets because a St. Bernard is big. Or remember BS for big skyscraper or big suckers. A disease with low, small platelets, as well as low B and T cells, is Wiskott-Aldrich. What are the clinical features of von Willebrand disease?
Petechia, bruising, bleeding gums, nosebleeds, and heavy periods.
Correct. You may also have prolonged bleeding after surgical procedures. And it's also a risk factor for postpartum hemorrhage. If symptoms are mild, what can you use to treat von Willebrand disease?
For mild symptoms, you can use desmopressin, which will release more von Willebrand factor.
Correct. What if the disease is more severe?
More severe von Willebrand disease, you'd use cryoprecipitate, which containing the von Willebrand factor and factor 8.
Yes, you can also give this cryoprecipitate as prophylaxis before surgical procedures in patients with von Willebrand disease. Don't give aspirin to patients with von Willebrand disease because it can worsen bleeding. Okay, back to platelet adhesion. What happens after GP1 on platelets binds von Willebrand factor?
You get calcium, ADP, and thromboxane released from the platelets.
Correct. I teach the cat's out of the bag, CAT, to remember that. What role will each of these factors play?
I'm not sure what the calcium does, but ADP binds the P2Y receptor on platelets and causes aggregation. And thromboxane vasoconstricts and also activates GP2 on platelets and causes aggregation.
Good. Calcium is a cofactor for several reactions in the coagulation cascade. What class of receptors is the P2Y ADP receptor? And how does the signaling cascade increase aggregation?
It's G inhibitory. ADP binding lowers cyclic AMP, and this is associated with more GP2 activity and platelet aggregation.
Good. ADP binding also increases thromboxane synthesis. What antiplatelet agents can be used to block the P2Y receptor? And list their side effects.
This includes clopidogrel, ticagrelor, and you have easy bruising and bleeding.
Correct. You can remember the GR in each drug for aggregation. So you said that low camp increases platelet aggregation. Therefore, high camp must decrease platelet aggregation. What antiplatelet agents exert their effect by increasing camp? And what class of drugs are these?
So the ones that increase camp are dipyridamole, cilostazol, and milrinone, and they're PDE3 inhibitors, and they stop the breakdown of camp.
Correct. What are the other uses of these drugs?
I know cilostazol can be used in peripheral artery disease. Milrinone is used in congestive heart failure. I'm not sure about the dipyridamole.
That's correct. Since increasing camp also results in smooth muscle relaxation, which is mediated by the G stimulatory pathway, where protein kinase A inhibits myosin light chain kinase, these three drugs dilate arteries. This effect makes milrinone useful in reducing afterload in decompensated heart failure. The elevated camp also increases cardiac contractility. While milrinone does have antiplatelet effects, it would not be used strictly for this reason. Dipyridamole can be used in combination with aspirin to prevent a recurrence of a stroke. Dipyridamole can also be used in pharmacologic stress testing. It will dilate the coronary arteries, causing coronary steal syndrome, with resulting ischemia to heart tissue supplied by atherosclerotic coronaries, which can be detected on ECG or imaging. Don't confuse PDE3 inhibitors with PDE5 inhibitors. What's the mechanism of action of PDE5 inhibitors, and what do they treat?
PDE5 inhibitors like sildenafil stop the breakdown of cyclic GMP after nitric oxide increases cyclic GMP. Cyclic GMP relaxes smooth muscle and blood vessels. These drugs are used for pulmonary hypertension and erectile dysfunction.
Correct. Which antiplatelet drug will reduce levels of thromboxane? What are some important side effects of this drug?
The antiplatelet drug that reduces levels of thromboxane is aspirin, and it's an irreversible COX-1-2 inhibitor that reduces the thromboxane. It can cause peptic ulcer disease by reducing prostaglandins. It causes multiple renal pathologies as well. It can affect the inner ear and cause tinnitus, and it can cause metabolic acidosis.
Correct. Renal disorders that aspirin can cause include acute tubular necrosis, acute interstitial nephritis, and renal papillary necrosis. Aspirin constricts the afferent arteriole and reduces GFR and renal plasma flow. Remember, aspirin causes a high anion gap metabolic acidosis, in part because aspirin is an electron transport chain uncoupling agent and can cause lactic acidosis. The acidosis will be preceded by a respiratory alkalosis because aspirin will increase respiratory rate. How can we eliminate aspirin in an overdose?
It's a weak acid, so you can use sodium bicarbonate to help eliminate it in the urine.
Correct. Describe the pharmacokinetics of aspirin.
Aspirin follows zero-order kinetics like ethanol, so the rate of elimination remains constant and is independent of the plasma concentration of the drug.
Correct. Phenytoin also follows zero-order kinetics. You can remember these three drugs with PEA, or zero Ps, or that a P is round like a zero for zero-order kinetics. What other toxicities is sodium bicarbonate given for?
It's given for a TCO overdose.
Yes, and a barbiturate overdose. It can also be used for hyperkalemia. Back to the GP2 receptor on platelets. What is this a receptor for? Which antiplatelet drugs can block this receptor?
GP2 is the fibrinogen receptor, and it can be blocked by tirofiban, eptifibatide, and I think abciximab.
That's correct. The fib in the drug name is a clue, like fibrinogen block. In a question, you would see these given to a patient before doing PCI. Name an autoimmune disease that involves the GP2 receptor and a genetic disease where GP2 is deficient.
An autoimmune disease that involves GP2 receptor is ITP, and a genetic disease where GP2 is deficient is Glanzmann thrombasthenia.
Correct. In ITP, immune thrombocytopenic purpura, you look for a patient with isolated low platelets. Don't confuse ITP with TTP, which has low platelets and low red blood cells. Glanzmann thrombasthenia has abnormal platelet aggregation, whereas Bernard-Soulier has abnormal adhesion. Finally, don't confuse Glanzmann thrombasthenia with essential thrombocythemia, which is due to a JAK2 mutation. What are risk factors for ITP?
Risk factors for ITP are a person had a recent viral infection, lupus, and I think hepatitis C.
Correct. Also look for an older man with CLL. Lupus and CLL can also cause another autoimmune cytopenia. What disorder is that?
Warm autoimmune hemolytic anemia.
Yes, along with drugs like penicillin or methyl dopa use in pregnancy. You can treat ITP with steroids. It's useful to know that thrombopoietin is a hormone produced by the liver that stimulates platelet production through the JAK pathway. And we administer thrombopoietin receptor agonists, such as romiplostim, to increase platelets. Now that we have a primary platelet plug, let's discuss the coagulation cascade and secondary hemostasis and creation of a stable fibrin clot. Let's trace the extrinsic pathway, the intrinsic pathway, and how they converge on the common pathway. Tell me how the extrinsic pathway is activated and how it converges on the common pathway.
The extrinsic pathway is activated by damage to blood vessel endothelium, which releases tissue factor. This binds and activates factor 7, and this complex activates factor 10 in the common pathway.
Correct. What is the pathology if tissue factor inappropriately activates the coagulation cascade?
It would be disseminated intravascular coagulation.
Correct. What are a few common causes of DIC?
Sepsis, traumas, obstetrical conditions.
Correct. Which obstetrical conditions?
Placental abruption, preeclampsia, amniotic fluid embolism.
Good. Also postpartum hemorrhage, HELP syndrome, and a retained placenta or stillbirth. What about a malignancy that can cause DIC?
AML.
Yes, AML and the AML subtype APL. These contain our rods. When leukemic cells lyse, our rods and procoagulant factors are released, and these trigger DIC. Also remember blood transfusions and pancreatitis as causes of DIC. What are the lab values in DIC?
So DIC has low platelets, increased bleeding time, increased PT and PTT, and it has low fibrinogen.
Correct. D-dimer will also be elevated, a fibrin split product, because of increased plasmin activity. Some patients with DIC will bleed more, and some will clot more. Finally, remember that we will monitor the extrinsic pathway with PT. How is the intrinsic pathway activated?
The intrinsic pathway is activated with exposed collagen and kallikrein, which activate factor 12. 12 then activates 11, which activates 9.
Correct. How does the intrinsic pathway converge on the common pathway?
9 will activate 10 using 8 as a cofactor.
Correct. In addition to von Willebrand disease, what is another disease in which factor VIII can be deficient?
In hemophilia A,
Yes. What is the inheritance pattern and clinical features of hemophilia A?
it's X-linked recessive. And patients get bruising, bleeding gums, nosebleeds, and bleeding into joints.
Correct. The hemarthrosis will distinguish hemophilia A from platelet deficiencies. Also, an infant might bleed more at circumcision with hemophilia and von Willebrand disease. It would be unusual for a woman to get hemophilia A, but explain how this could happen.
So a woman could get hemophilia A if she had Turner syndrome and only one X chromosome.
Good. She could also have skewed inactivation of the X chromosome, or she could inherit the defective gene from each parent. Remember that in addition to factor deficiencies, you can also get antibodies that inactivate factors. How would you distinguish this?
In a plasma mixing study where the factor deficiency will correct, but the antibody inhibitor will not.
Good. Once factor 10 is activated by either the intrinsic or extrinsic pathways, take me through the steps that lead to conversion of fibrinogen to fibrin.
Factor 10 will convert prothrombin to thrombin using factor 5 as a cofactor. Thrombin will convert fibrinogen to fibrin.
Correct. Do you know some pathologies related to factor 5 and prothrombin? These involve hereditary thrombophilias, a genetic predisposition to clotting.
There's factor 5 laden mutation, where factor 5 can't be inactivated by protein C. I'm not sure about the prothrombin.
You can inherit a prothrombin mutation that results in increased prothrombin expression. In a question, suspect these disorders in a patient with increased clots who doesn't have the typical risk factors for clots, like Virchow's triad of stasis, hypercoagulability, and endothelial damage. Do you know any other hereditary thrombophilias?
There's antithrombin 3 deficiency and also protein CNS deficiency.
Yes. These are more typically acquired than hereditary. What is antithrombin 3's main function, and how is this deficiency commonly acquired?
Antithrombin 3 inhibits factors 10 and 2. Antithrombin 3 deficiency is acquired in nephrotic syndrome.
Yes, antithrombin 3 deficiency can occur if you lose it in the urine, like in nephrotic syndrome, or you don't synthesize it, like in liver disease, or you consume too much of it, like in DIC. Patients with antithrombin 3 deficiency present with DVT, PE, and even renal vein thrombosis. A patient with antithrombin 3 deficiency can have resistance to heparin. We will discuss this in a moment. What is protein CNS's main function, And how is this deficiency acquired?
The protein C and S complex inhibits factors 8 and 5. I'm not sure how you acquire a deficiency, though.
Protein C resistance and protein S deficiency occur in pregnancy or with OCPs, making the patient hypercoagulable. A patient with protein C deficiency can have increased skin necrosis with warfarin use, and we will discuss this in a moment. Name, name a hypercoagulable genetic condition that resembles Marfan syndrome. What is the most common enzyme defect in this condition and its cofactor?
This would be homocystinuria. I'm not sure what the most common enzyme defect is. I know a defect in methionine synthase can cause it and can cause megaloblastic anemia.
Yes, that's an enzyme defect that could cause homocystinuria, or a B12 or folate cofactor deficiency could also be at fault. The most common enzyme defect would be cystathionine synthase, with B6 as a cofactor. There are several mechanisms by which homocystinuria leads to a hypercoagulable state, and it leads to accelerated atherosclerosis and early stroke and MI. Can you name another acquired thrombophilia?
Antiphospholipid syndrome.
Correct. Antiphospholipid syndrome can be primary or secondary to lupus. What are the three autoantibodies involved and the clinical features?
Anticardiolipin and lupus anticoagulant are two of them. Um, Patients get DVTs and PEs and miscarriages. I know they also get a false positive syphilis test.
That's correct. Anti-beta 2 glycoprotein is the other autoantibody. Patients also get arterial occlusion causing stroke, MI, or gangrene. They may also get livedo reticularis, a blue net-like pattern on the skin. Patients will be treated with aspirin and warfarin to prevent clots. If the patient is pregnant, heparin will be used instead of warfarin. Always remember that the liver makes clotting factors. So a patient with liver disease will typically have an elevated INR. There is a balance between clot formation and clot breakdown by fibrinolytics. What molecule breaks down clots, and how is it generated?
Plasmin breaks down fibrin clots, and TPA converts plasminogen to plasmin.
Correct. What are some uses of recombinant TPA, such as alteplase?
It's used in DVTs and PEs, ischemic strokes within the first 4.5 hours, and for STEMIs.
Yes. If we give TPA outside of the 4.5 hour window in an ischemic stroke, we could cause a hemorrhagic stroke. For STEMI, TPA should be given within 30 minutes of medical contact. There are many contraindications to taking TPA so that we don't cause intracranial hemorrhage. TPA can increase both PT and PTT. If we administer too much TPA, how can we reverse it?
You can give aminocaproic acid.
Correct. We can also use tranexamic acid. These agents are used to control bleeding in some surgeries and postpartum hemorrhage. Let's discuss some of the other medications that inhibit the coagulation cascade. What is warfarin's mechanism of action?
Warfarin stops vitamin K activation by inhibiting epoxide reductase. And vitamin K is a cofactor to activate clotting factors 2, 7, 9, and 10, as well as protein C and protein S.
Correct. What is the mechanism of warfarin-induced skin necrosis?
Warfarin depletes the anticoagulants protein C and S before the procoagulant factors, making you hypercoagulable.
Correct. And that's why we will use heparin bridging anticoagulation until warfarin begins to work. And remember that the skin necrosis is worse if you have a protein C and S deficiency. How is warfarin monitored?
You can monitor warfarin through the PT or the INR.
Correct. Where is warfarin metabolized? And what are some of its drug interactions?
Warfarin's metabolized by the cytochrome P450 system. If you take a P450 inducer like rifampin or phenytoin, you would have to increase the dose of the warfarin. If you take a P450 inhibitor like omeprazole, erythromycin, or isoniazid, you would have to lower the dose.
Correct. Remember that warfarin is a teratogen. What are some agents that can be used to reverse warfarin?
You could give vitamin K to outcompete warfarin for epoxide reductase, or you could give fresh frozen plasma.
Correct. Prothrombin complex concentrate is preferred over fresh frozen plasma because you need lower volumes, so you're less likely to cause fluid overload. Because PCC only has concentrated amounts of the factors that warfarin inhibits. The algorithm to reverse warfarin depends on INR and whether the patient is actively bleeding. If the patient is actively bleeding, you will administer both vitamin K and PCC. If the patient is not bleeding, but the INR is over 5, you may administer vitamin K. Remember, warfarin will be the drug of choice for anticoagulation if somebody has atrial fibrillation due to mitral stenosis or has an artificial valve, and you want to prevent a thrombus in the left atrium. What's the mechanism of action of heparin?
Heparin augments the activity of antithrombin 3.
Correct. What factors does antithrombin 3 inhibit?
Antithrombin 3 inhibits factors 10 and 2 equally.
Correct. Remember that a patient with antithrombin 3 deficiency can have resistance to heparin. What are some similarities and differences between low molecular and high molecular weight heparin?
Both are monitored with PTT. Both can cause bleeding and heparin-induced thrombocytopenia. Low molecular weight heparin is renally cleared. High molecular weight heparin is hepatically cleared, and they can both be reversed with protamine sulfate.
Correct. Heparin can also cause osteopenia. Protamine can fully reverse high molecular weight heparin, but it only partially reverses low molecular weight. Also, low molecular weight heparin is commonly given subcutaneously, and it has greater bioavailability and a longer half-life. High molecular weight heparin is more commonly given IV. What are some uses for heparin?
Heparin can be used for DVTs, PEs, myocardial infarction, and as a bridge for warfarin.
Correct. It can be also used as an anticoagulant in pregnant patients, since they can't take warfarin or the direct oral anticoagulants. Heparin is also contraindicated in strokes. What's the mechanism of heparin-induced thrombocytopenia, and how do we treat the patient?
So heparin binds to platelet factor 4, and this complex attracts an antibody that can cause platelet destruction by macrophages or platelet aggregation and thrombosis. I think you can treat the patient with direct thrombin inhibitors.
Yes, you would normally use agents such as argatroban or bivalirudin. Low molecular weight heparin is less likely to cause heparin-induced thrombocytopenia. There is a synthetic heparin called fondaparinux. It binds to antithrombin 3, but it only inhibits factor 10. It has less incidence of heparin-induced thrombocytopenia. We mentioned the direct thrombin inhibitors. Name the direct oral thrombin inhibitor and name the direct oral factor 10 inhibitors, as well as the reversal agents for both groups.
The oral direct thrombin inhibitor is the dabigatran, and apixaban is a direct factor 10 inhibitor. I'm not sure how they are reversed.
Well, that's correct. Dabigatran can be reversed with idarucizumab. The other thrombin inhibitors can be reversed with PCC. Apixaban can be reversed with andexanet alpha, which is an inactive factor 10A decoy. XA net, like catching 10A in a net. What are advantages of direct oral anticoagulants over warfarin?
They don't require INR monitoring like warfarin, and they have less drug interactions.
Correct. They also have less risk of intracranial hemorrhage. They are preferred agents for anticoagulation and atrial fibrillation if it's not caused by a valvular etiology like mitral stenosis. Don't use direct oral anticoagulants in patients with artificial valves. Similar to warfarin, direct oral anticoagulants are contraindicated in pregnancy. Thank you for joining us for our lecture on primary and secondary hemostasis. Additional lecture notes will be available at lectureboss.com. Take care.